going to talk about rotational osteotomies and really the difficulty with torsional deformities. So I'd like to thank my researcher for helping me with this talk. Really the pioneers of this thought process are really Robert Taiji, Vicente Sanchez Alfonso, and Frank Noyes. These thought leaders have been discussing this for years, and the Europeans have been doing it, but the Americans have been very hesitant. If we think about malalignment and torsional abnormalities, these are commonly ignored in the patellofemoral joint. They're an overlooked cause of anterior knee pain, and they're an overlooked cause for patients with and without patellofemoral instability, and they're definitely overlooked when it comes to the treatment of these conditions. The vast majority of orthopedic surgeons, specifically in the United States, they view the patellar malalignment as a problem of the patella and the trochlea. They think it's a patellar tilt, it's a patellar shift, it's tibial tubercle lateralization, or it's just trochlear dysplasia. But really, malalignment is of the entire limb. And it's really, we need to measure the limb and its coronal, sagittal, and really its transverse plane, its axial plane. So when we think we should think of limb malalignment, we shouldn't really think of patellar malalignment. This isn't an isolated thing. Rotational deformities are often really ignored. It's not just about increased varus or increased valgus. This is excessive femoral aneversion and excessive tibial torsion. And these all have a great impact on the patellofemoral joint. And so when you're talking about rotational osteotomies for skeletal malalignment, this is done to unload the patellofemoral joint. And this is just analogous to the same thing we've talked about for the previous sections on varus valgus deformities and unloading the medial and lateral compartments. When we talk about a rotational deformity of the femur, you really have to put a patient prone. All right, there's no other way to really do this. You have to put the patients prone, and this is why it's really missed in a lot of sports clinics, because we have so many patients and we just really don't have time. And you need a CT scan for the rotational profile. This also goes for tibial deformity. You need to put the patient prone. You need to look at their thigh foot angle, and you also need to watch these patients walk in the hallways to really see their gait progression. And this isn't just a pediatric thing. So when we look at femoral version, this is a really hot topic. There's 28 different ways to measure femoral version. Really, the Murphy method really correlates the best with physical examination, however. So that's what I use, and that's what this BodyCAD system uses as well. And really, you're taking a two-dimensional method, however, and now you're transferring it into 3 dimensions. For the tibial rotation, it's two-dimensional, and then it's converted to 3. But there's much less discrepancy on the way we measure on measuring tibial torsion than femoral torsion. And the problem is that the numbers we're kind of all over the place. Femoral torsion is really normal femoral aneversion is 17 degrees considered, and tibial torsion angle is 23 degrees. So I always start on the femur first when I'm looking for the deformity. Al Getgood recently looked at this analysis of the literature out there, because there's really not a lot of guidance, and femoral aneversion over 25 looks like it's pretty pathologic, and tibial torsion greater than 35 is kind of the numbers, but these numbers are different for all different studies. So we still really don't, the literature really doesn't tell us, what's the number to rotate at. If we start rotating greater than 20 degrees, however, we start getting in the risk of really nerve issues. But if we don't rotate enough, we have pain, and if we rotate too much, we have pain. So these are undecided issues. I never correct more than 20 degrees. The problem with distal femoral osteotomies is that torsion affects the axial plane, but due to the shape of the distal femur, if you don't do it perpendicular to the axial plane, you're going to cause a coronal malalignment. And due to the shape of the distal femur, a typical distal femoral osteotomy cut will tend to place, because the anterior bow of the femur will tend to place, if you do an external rotation osteotomy, you'll tend to place the femur in more valgus. And if you're doing this on a patient who has patellofemoral issues, you're going to actually make them worse, and you can worsen their instability. So a bunch of smart Germans came up with this mathematical proof that demonstrated that if you cut perpendicular to a virtual anatomic axis, you can basically give a slight varus correction instead of putting it into valgus. But instead of having to worry about this is where PSI is going to come in. So what are the reported outcomes? So if we look at some systematic reviews that were recently published, there's a high patient satisfaction rate on distal femoral derotational osteotomies. These aren't huge numbers, though. This is 309 patients over multiple studies. The complication rate in another recent study was 1.2%, but again, that's only 325 knees. There was no, really, the cutoffs on the derotation is different for each study, though, whether it's between 20 degrees of derotation, 30 degrees. This is still a work in progress. If we look at distal femoral osteotomies with MPFL reconstructions, they did better when you added distal femoral osteotomy to an MPFL reconstruction. And there's data that shows that if you're over 25 degrees of femoral anteversion, you have a much higher incidence of your failure of your MPFL reconstruction, which makes sense because the force vector coming from the quadriceps. So I do think, just like I said in the last talk, this is a game changer. We're much more accurate, and I think when it comes to derotational and rotational deformities, this is really a must. This is an example of a patient I have. This is a 24-year-old with recurrent bilateral patellofemoral instability and anterior knee pain, right worse than left, but pain on both. She has 41 degrees of femoral anteversion. She has 34 degrees of tibial torsion. She has a TTTG of 21 millimeters and a CDI of 1.1. So not really patella alta. I'm going to do a biplanar cut. This has been described by Hinterwinter. This is an anterior closing wedge, and this will give us more surface area on our derotation because derotations are highly unstable. I'm going to use a bump. I'm going to use in the operating room. I'm going to use, just like we talked about in the last, radiolucent retractors. The guide placement is key for this. And the cool thing about this system is the holes are pre-drilled. So we drill the holes for the plate. So we know where the plate goes because when the bone rotates, the plate can only go where those holes were drilled. So we know immediately. I'm going to use a clamp to help reduce it. And then I'm also going to use an AP screw. I've been adding this separately, just an AP screw to the anterior flange, just to give a little bit more compression at this site. Again, I'm going to keep the patients over 23 hours, keep a drain in place. I'm going to go really slow on their motion for the first week. Just really let them, if I use a CPM, it's only 0 to 45 degrees. I'm going to encourage them to do isometric quads, and I'll see them the first week after surgery, see what their swelling is, and then we'll start formal physical therapy. This is an example of one of my patients who had a failed TTO and MPFL reconstruction. They had 35 degrees of femoral anteversion, and they had a distal femoral derotational osteotomy, a revision TTO, revision MPFL, and this is them 3 years after, and now they're playing basketball at actually one of our major schools. This is a high school basketball, but one of the major feeder schools in Los Angeles. Just a last case. This is a 28-year-old female, recurrent left lateral patellar instability, anterior knee pain, and a cartilage lesion on her patella. She's, in these type of cases, I'm going to do she has a femoral anteversion of 42 degrees, tibial torsion of 51, and a TTTG of 26. Just moving her tubercle is actually going to make this patient worse. If a patient has extreme tibial torsion, if you move their tubercle medially, you're going to actually increase their problems because they're going to have to move. They're going to externally rotate their foot when they walk because you've moved them so far medially. And so there's biomechanical evidence that shows that as well. So I'm going to stage this. Stage 1 will be a distal femoral derotational osteotomy. And then stage 2, in about 8 weeks, we'll come back, and then we'll do a derotational tibial osteotomy with a tubercle osteotomy as well. I'll do an OCA of the patella and an MPFL reconstruction, and allograft the plug of the patella. And this is this patient at 7 months post-op. These are too big of surgeries to do, in my mind, all at once. So I'll typically, if I'm doing a do rotationals, I'm gonna stage them apart. If I'm doing any type of cartilage work, I'm gonna stage it. The patient's got too big of a risk of getting stiff. It's just a lot to ask. So the take-home message is that torsional abnormalities are present. We just need to look for them, and we can't ignore them if they're severe. Changing limb alignment by osteotomy is really the single most powerful thing and the most underutilized thing we can do. The quadriceps is responsible for this. So the osteotomy is able to change the quadricep force, and if we don't address these things, doing any other work in the knee is doomed to fail. And preoperative digital templating, in my mind, is really the way of the future, and I won't do the surgery freehand anymore. So, thank you.